hold your enthusiasm before I pass to Dr. Beccy Cooper, please.
Lovely, thanks, Chair. So yeah, very much continuing in the vein that you're going, I would like you to concentrate for us on the Falls Management Exercise Programme, please. So FAME, as it's known. Excellent. So I just wonder...
Live forever.
Yes, nobody wants to live forever. So I wonder if you could outline, perhaps Dawn, if we could start with you, if you could just outline for the committee, what is the criteria currently for accessing this programme?
It's a postcode lottery. So in some areas you have to have had a fall. In the last 6 months, for example, other areas you just have to be concerned and avoiding activity. In some areas you have to have both. In some areas you have to be signposted through a physiotherapy department, which might have a 9-month waiting list before you can even start. Other places it's self-referral. So unfortunately it's not equitable at the minute.
That doesn't sound great. So it's not standardised across the country is what you're telling us. So that sounds like it should be. And sort of moving on from that, do you have a sense of what the coverage is across the country? You said it was a postcode lottery. Is there a percentage as to the coverage? Is it better covered in the south, better covered in the north? Liz, you look like you're nodding your head.
Yes, because we've just done a survey of all local authorities, ICBs, health boards across the UK, and we see that we're specifically asked about the commissioning of FAME, and we only see commissioning of FAME in 5% of ICBs, 5%, and 15% of local authorities. Now, that's not to say they're not providing something, but we specifically asked about FAME because that's the programme that has the best evidence to prevent falls.
Okay, and I wonder if I could just pick up on the commissioning issue there, because obviously you've mentioned integrated care boards, which is our health commissioning, and local authorities, which is our public health commissioning. Do you have a sense as to where this commissioning should actually sit, bearing in mind we're moving to strategic commissioning for ICBs, but public health, to the best of our knowledge, is essentially remaining in local authorities? Do you have a sense of where it should be commissioned from?
Yeah, so I think you need to look at the spectrum of physical activity through to exercise as treatment. And you have to think about, so that's from kind of primary prevention right the way through to treatment. So I think in my view, you have the local authority public health teams have a responsibility for commissioning physical activity programmes that are primary prevention, from the kind of campaigns of moving everybody a little bit left, that left shift, a bit more active, the inactive to being active. That in of itself is really important. There hasn't been good enough messaging around strength and balance component of the Chief Medical Officer guidelines. We tend to focus on the 150 minutes solely in our messaging, and that strength and balance is so important. It's part of the guidelines.
Sure. So sorry, Liz, just to be clear, from what I'm hearing from you, is that the commissioning for FAME should rest with public health bodies in local authorities? No,
because so I think that as we shift into people who are at risk of falling because they've had a fall or they fear of falling, then we start to shift into exercise as treatment, and it's prescribed and it's progressive and it's tailored to the individual.
So this sorry, Liz, apologies, it might be a misunderstanding, but is FAME not a falls prevention programme?
Absolutely is.
And sorry, just going back to what Dawn said, in terms of who is able to access it, it may well be that some people are accessing it who have not had a fall yet, so it's pre-frailty potentially.
So it's people who are at risk of falling, so you're starting to get into the kind of secondary prevention.
It's not primary prevention, it's secondary prevention.
I mean, it can be used in that way, but it is primarily, when resources are constrained, it's a secondary, I'd be putting it in the secondary prevention. And this is not uncommon in health improvement where you have a spectrum. Weight management is the same.
I absolutely appreciate that. I think I'm just, for the benefit of the committee, if we're making recommendations.
Absolutely. So I would say the ICB is where we start to see treatment services, physical exercise as treatment. In public health, we've got exercise as
I absolutely hear you. The Falls Management Exercise Programme
has evidence for both.
Has evidence for both. Thank you. Excellent. So it's indeterminate where it falls. That's what I'm trying to get to.
And that is part of the problem because of the complexity of the system and the current lack of clear commissioning guidelines about where it sits.
Great. Thank you. That is clear in its lack of clarity. Yes, thank you. So perhaps moving on to some specifics around the FAME programme. You were talking earlier to my colleague around the people who are delivering falls prevention and their training not necessarily being holistic, if you like, sort of looking at their specific areas. So the FAME programme, I understand, at least should be delivered by postural stability instructors. Is there a specific training programme for postural stability instructors?
There is, and it's not a half-day online. It's a face-to-face, practical delivered. They get assessed on their practical delivery, their behaviour change discussions, their exercise science knowledge, their progression, their understanding of long-term conditions. See, we have, again, going back to where that fits in the continuum, we have physiotherapists, we have clinical exercise physiologists. They do treatment, generally outpatient hospital treatment. Then you've got your exercise referral instructors, physical personal trainers, etc., dance instructors. There's a massive gap between people leaving there and going there. So there used to be a framework called Level 4, Specialist Exercise Instructors. So your cardiac rehab, pulmonary rehab, cancer rehab, postural stability instructors. And they were all set at essentially an undergraduate level training with practical assessments. Things have changed a bit. Now we have a new governing body of the exercise world, and I think we just need to make sure we support that group, because they do all that training and it's hard to pass, and not everybody passes, because it's really important that we get it right for these people that need a timely, effective programme. The issue is that they're nearly all on 0-hour contracts. So of course during COVID we lost loads of them because there was no job security, etc. They're not offered any support in terms of CPD. Later life training that trains them offer a lot of CPD, and a lot of it really, really on cheap because it's not a profit company. But we're not professionalising. We're not treating them with the same respect that we treat physios and clinical exercise physiologists. And yet it's a professional workforce.
Which is really interesting, Dawn. So just very quickly, their backgrounds generally are what? So what
exercise instructors.
So they
start
come from being
personal trainers. They then do exercise referral. So they've got a knowledge of the lower risk health conditions and how to manage those. But PSI, postural stability instructor, brings in that real behaviour change for dose, because someone can come once a week to an evidence-based programme and you will sort of get an effect. But if they do 2 hours a week, the dose is right and it's progressive, so they have to do home exercise in between. And that's really important when you've got someone who's frailer, because they'll compensate. They'll go, oh, I went to a class this week, I'm too tired to do anything tomorrow. So the physical literacy, the education is really important. The behaviour change, the problem solving. So the training has to be in that. So it's not a case that anybody can do that. A volunteer can do a half an hour online training, a care worker can do. They don't have those skills, and they're not assessed in those skills. So this is why it's important for that work.
No, and that's really clear. Thanks so much. So just one final question for me around the cost of the programme and the return on investment. So I'm presuming evaluations have been done. Has a cost-benefit analysis been done? And what is the ROI? Who would like to take that?
Well, the original, so Public Health England and the Falls and Fragility Fracture Group did the social return on investment at £2.28 per individual.
Say that again.
£2.28 returned for every pound spent.
For every pound spent. Okay, yes. So. Okay.
We have more recently updated those costs, because obviously that was done a number of years ago, and costs have increased and changed and so on. And now I'm going to kind of look at Dawn, because I forgot the precise figure. £2.43. There you go. So we've updated that. It's not yet published. We're just about to submit that for publication.
Okay. That's just looking at falls as an outcome. If you look at Gateshead Old People Assembly, they did their own version of a cost analysis, looking at health and social care provision and a variety of other things, and they came in at £50.89 per pound invested.
Wow. Okay, so just to be clear, would your recommendation as a panel be that falls management exercise programmes should be commissioned consistently across the country as a secondary prevention programme, potentially with some primary prevention in there as well?
That and Otago, because there are two programmes in the UK that have an evidence base. Otago is for the frailer. So it really works more for those who are over 80. But those two programmes have really been shown. I just want to just say one thing. There's been massive number of studies in exercise to prevent falls, nearly 200 randomised controlled trials. Half of them have not reduced falls. They've been designed by people that think they know what they're doing. They improve strength and balance, risk factors for falls, but they don't reduce falls. So we can fiddle all we like around the edges and go, we think we're doing a good programme. We don't know, but we do know that FAME and Otago work, both in randomised controlled trials and real-life studies. So we shouldn't fiddle with something that might look more interesting, a bit more fun, a bit more... We've got no time with these people. You know, within a year of a frequent faller, someone who's falling more than 3 times, within a year, 20% will be dead in a care home or in hospital. We haven't got time to muck around the edges. We have to offer an effective treatment in a timely manner.
Okay.
And just to go one more stage on that, and Dawn's completely right, it's got to be effective, so people have to follow the actual protocols of what you should be doing. You shouldn't be reducing it because, oh, Mrs. Smith will struggle with that. Well, actually, being progressive and making sure that you have to put some effort in is exactly the issue here. So we've really got to make sure that it's delivered by properly trained
Well, in the same way,
personnel.
you wouldn't fiddle with a dose of medicine, would you?
No, you wouldn't.
There you
Exactly
are.
so.
Thank you.